Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. During these troubling times, we're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
My name is Kelly Batley.
My name is Clay Thompson.
My name is Neil Mowney.
We are MRHFM, a national firm with 70 attorneys and 11 offices across the U.S.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
At Novacure, we strive to extend survival in some of the most aggressive forms of cancer through the development and commercialization of our innovative therapy called Tumor Treating Fields. Novacure is pleased to partner again with the Meso Foundation.
This is a really exciting time with new treatment options, with the Checkmate 743 data. And I think that the question that comes up a lot for clinicians and for patients and other people as part of our community is how do we start to parse it apart and decide really who should get what? And the questions that we field a lot have to do with, well, should everyone get immunotherapy? Who should still get chemo? When should we use bevacizumab? And what about the Optune tumor treating fields? So I wonder if maybe you could both sort of talk to me a little bit about your thought process when you're meeting someone and you're making these decisions for frontline therapy. What are sort of the factors and variables you're considering?
So in UK, it's relatively straightforward because bevacizumab's not approved and it's not reimbursed. So for the majority of patients, it's really not even on the menu to have that discussion. There are some patients who are privately insured where we have previously had that discussion, and I have to say we've been trying to combine it with cisplatin as per the trial data. So they have to be a cisplatin eligible patient, well enough to cope with cisplatin. I've tended to favor it on my non-epithelioid patients before because of the multivariable analysis showing the benefit tended to be stronger in that group of patients, but otherwise patients have generally been receiving standard platinum pemetrexed chemotherapy with a view to immunotherapy on relapse. And only now, where we've started to very recently in the UK have early pre-label access to immunotherapy, then these issues have started to come up. My personal view on 743 is that if you're non-epithelioid, it's a slam dunk really for immunotherapy, and really I think there's a very limited role for chemotherapy in that setting if nivo-ipi is available. It's much more nuanced in a epithelioid patient because the progression-free survival curves tell a slightly different story, with a very early rate of progression in the first 7 months for many patients. So part of the question is really how secure do they need a response or non-progression within the first 7 months? For some people that are going down a surgical paradigm, I still think we don't have enough data on checkpoint inhibitors combining with surgery in a multimodality treatment. So I would very much want to treat those patients with chemotherapy as induction and we also then have much more secure PFS data for chemo as induction prior to surgery. But otherwise, I think it's very unknown personally as to who to select for immunotherapy and who not to. Personally, I think that the data on PD-L1 is a mess and not really easy to read too much into in the frontline setting.
I think that summarizes it very well. From my perspective, these are much more complex discussions, and sometimes patients really want certainty, and you have to provide them with nuance. So, one key question is that patient a clearly surgical candidate or not? And that will change your paradigm, because we don't have sufficient data with immunotherapy in the context of surgery, or even whether immunotherapy can replace surgery, but that's a whole nother discussion. But in the patient where we're starting out with treatment, clearly I will look for, are they epithelial or non-epithelial? And I agree, in that patient who has pure sarcomatoid or sarcomatoid predominant biphasic histology, they are slam dunk, absolutely no question, going to get immunotherapy, unless they have certain reasons why I can't, such as they have severe autoimmune disease or other reasons why it's simply not feasible, and that's uncommon. And then in the pure epithelial patient, that's the really nuanced discussion. And we will look at PD-L1 in all of our patients, and I agree, it's a minefield. We don't know the utility of that. But in a PD-L1 high, I'm going to be probably more likely to want to offer immunotherapy. And in a PD-L1 0, we're truly going to have that nuanced discussion. Epithelial, no PD-L1 expression, we have either option. And then if we're going to talk about chemo, it's pemetrexed with cis or carbo plus or minus bevacizumab. In the US, when we want to give bevacizumab, many insurance companies, at least in our region, will not allow use of it with carboplatin. Even though there's phase 2 data, there's not phase 3 data. And then the question is, well, is that patient well enough or appropriate to get the toxicities of cisplatin? So just there are multiple different issues. So in general, I'm more inclined to offer immunotherapy when I can, simply because of the long-term outcome data. But patients need to be aware of the less predictable toxicities with immunotherapy, which some of them are not as eager to receive. You know when you're going to get nausea, vomiting, lowered blood counts, neuropathy, et cetera. With chemo, you don't know when those things might pop up with immunotherapy. That being said, there's a lot of wonderful advertising about immunotherapy, and patients have this feeling that this is this magical treatment. And so you have to ground them in reality of what the side effects are, that there are side effects, but that this can offer promise for longer term disease control.
And so, I guess the next question I have related to that is, if you give, let's say, an epithelial patient and you have this really nuanced conversation and you make the decision for high PD-L1 or some other reason, and you give them ipilimumab and nivolumab for first-line therapy, and then at some point they do progress, what are you then thinking for second line? Are you going to do a platinum doublet in the second line space? Does everything kind of get shifted back, or how do you approach that decision?
So in a disease that you, still cannot adequately control, we always have to offer clinical trials for patients at any point in time. And so I think that this is an optimal place to offer patients novel clinical trials. That being said, not every patient has access to them. We don't really have great data about what's the best second line setting, treatment in this setting, but it naturally falls to thinking about a platinum doublet as certainly an excellent possibility. There also is further data that came out this past year at ASCO on the RAMES trial, which was gemcitabine plus or minus ramucirumab, that I think was a sleeper that surprised many of us because it showed a doubling of survival in this patient subset. But were those patients who had previously failed immunotherapy? No. Were those patients who had previously received bevacizumab? Don't know. So, where does that fall? And at least in the US, it's really hard to get ramucirumab in the second or third line setting. Occasionally I can, convince some insurance company, but it's hard. So I think without sufficient data, I think the best data is a pemetrexed doublet or triplet, but I think we need further exploration to see. And if a clinical trial is available, I think we need to do that at that point because we still need to investigate new therapies.
I think that's right. I mean, in the UK and most of Europe, ramucirumab is just not available, so that's just not even on the agenda. And like all trials of checkpoint inhibitors, interestingly, the majority of the survival benefit is given by post-progression therapies. Because if you look at the survival advantage, it's much bigger for OS than it is for progression-free survival. So to me, I think post-progression therapies is a really important thing that we need to think about. And my worry is that oncologists are just not going to give it, and mainly because patients won't want to stop their immunotherapy. What we've seen in lung cancer is that we give a first-line checkpoint inhibitor and the disease is progressing. We ignore it, say maybe it's just a bit of pseudo-progression. We do another scan, it carries on growing, patient's feeling good, and we just watch it getting bigger and bigger and bigger, and then soon the patient is really not very keen on more treatment.
Or they're not well enough, right?
We have all of these issues. So actually my concern is that we're going to have patients starting immunotherapy who then progress at some point. Maybe they respond or maybe they don't respond, but actually that never get to the window of opportunity to get the chemo in the first place, when actually that's probably what they needed to get the real driver of their disease. I think we're going to have to see how this field just plays out over the next year or so, but we do need to have open discussions with our patients that yes, we want to start immunotherapy in most of our patients, but actually in many of our patients it may not be the right drug combination for them. We may need to go down the chemo route thereafter. But I totally take your point, Hedy. This is a really interesting area for research. And actually, when we've got this cohort of patients where we see a response, can we consolidate that response after they then relapse? If they've shown that they've got immune sensitive disease, if they relapse within 3 months, that's a completely different ballgame to relapsing a year and a half down the line, having had a really durable benefit from a checkpoint inhibitor. In that latter patient, I'd be far more interested in a novel checkpoint inhibitor combination in a trial to try and re-synergize some immune control than I would be for chemo. But this is an area that we're all learning about together, I think.
Well, some of those patients who have discontinued after their 2 years worth of checkpoint blockade and then who progress can be retreated with those checkpoint inhibitors and again develop sustained control. And certainly patients who have been treated with single agent, in our experience, can then and progress can still respond to the doublet. So we're simply learning all about this. And then of course there comes what's the role of chemoimmunotherapy. And that's an even more unknown. There are single-arm phase 2 trials that are very promising. There is a phase 3 trial from Canada that should be reading out shortly, and another ongoing international study with durvalumab that's still ongoing. And then, of course, you have your studies that you can tell us about. So, where this will play a role, and should that be the optimal treatment for the epithelial patient, who may need both chemotherapy and immunotherapy, I think that's, a great unknown.
I totally agree. I mean, this is really where we're learning and moving forward. And I just think it's great to have these trials available with chemo and immunotherapy. And I'm just delighted that we can coordinate all of these globally and work with patient groups and patients themselves really to try and answer these questions. It's going to be really very interesting to see how this field matures. Marjorie.
But one concern that I have is that whenever we have a new treatment in any disease, oftentimes people will adopt that and then move away from clinical trials because, hey, we've got this great treatment. And I think patients need to understand we're not there yet. We're not curing all of our patients. We're not controlling this disease long enough in enough patients. We still need clinical trials. We still need to investigate further.
Yeah, sorry. I was just going to say, I could also envision a future where we know better because of biomarkers who should get what. right?
And that's what
And
we need
I,
to study.
you know, and I think right now we're all struggling in this nuanced way to find surrogates that improve the statistical probability that we're picking the right thing at the right time. But I can see a future where we maybe know, well, this person needs chemo IO, but this one should get double checkpoint inhibitors. And I think that we focus a lot on the clinical trials, but I think the part that sometimes doesn't always get conveyed to the patient so well is that we don't ask for these biopsies and blood samples just because. We ask for them because they're so important to really propel the field forward and answer some of these nuanced questions with data.
Absolutely. Each patient can teach us more about what to do for the next patient.
I think that's really critical, actually, because in a field where we are giving a lot of extremely expensive drugs, where we're seeing a lot of extremely difficult side effects coming out at a very unpredictable time, we need to do much better in actually identifying which patients benefit the most. So I very much echo everything that you said, Marjorie, is that we need to completely redouble our efforts to be ensuring that we have as much biological outputs for each of the translational studies that we're all doing to try and get to the bottom of this. Who needs the right drug at that particular time point?
So, you know, the only other thing that jumped out to me when you guys were talking too is I've certainly had situations and seen other patients treated elsewhere where there's also oligo progression after immune therapy. And I just wondered how much you guys are using perhaps locally ablative or local therapies to address an isolated lesion, perhaps.
We have a whole center of research for oligometastatic disease, and I think that's a really important component. And so your patient has a solitary progression and other disease is still being controlled, you can indeed, use focal radiation or whatever your approach for that particular patient to try to ablate that, potentially create an abscopal effect if that exists, and then continue. And again, if your patient is getting generalized control, but one thing is causing a problem, which one are you going to weigh? Is it more important to just worry about that one guy, or do you really want to control the disease in its entirety?
Yeah, I tend to agree. Although the data that supports all of this is really pretty thin at best, and actually, what we really need to do is to collect this data and present it, because we in the UK and certainly most of Europe, it's not standard to give SBRT to an oligoprogressive lesion, and certainly in the UK, it's not reimbursed. And so we can't really say, look, we have this amount of data to support this practice. I know it happens, and we do it in insured patients, but it'd be really great to try and collect some of this data to show actually, so if we are going to be controlling this lesion with a local approach, be it SBRT, what is the median benefit that we're getting here before we're then needing to change our systemic therapy to something else? There is a nice data set that's come from our Zurich colleagues on SBRT retrospectively, but otherwise it's pretty thin. It's something that I think
studied prospectively, and
yeah, absolutely. No, we do need to really create that scientific environment that we can collect that in. But if I look at what we've done in lung cancer, we're seeing the same things here happening in meso. So we're starting off with checkpoint inhibitors up front, and yeah, we're seeing actually in lung cancer, we're seeing quite high rates of oligoprogression. And in lung cancer, we are treating these with local approaches where reimbursed and feasible, etc. So I see no particular rationale not to do the same thing in meso as well. Bearing in mind, we've got a slightly different scenario with the pleura involved, and technical aspects to treating the diaphragmatic recesses can be challenging. But yeah, I think that's an area that we just need to collect far more data on, really, to be very sure that that's the right thing to be doing.
And of course, meso is not lung cancer. We can extrapolate, but only so much. And we need to understand that it's still a separate disease. But indeed, and when you're looking at something as heterogeneous as oligometastases, you really have to also design the prospective studies appropriately, because it can be very challenging to interpret.
Absolutely. So where does Novocure's Optune TTF fit in? I mean, that's something that comes up a lot in my practice, comes up a lot for the foundation. So I don't know if either of you have used it or what your thoughts are about that device.
Well, it's simple from Europe because it's not approved and not reimbursed, so it's just not even a discussion point. And my personal view on it is I don't think we have enough data with which to make a decision on whether it's usable or not. But hey, Hedy and Marjorie, you'll have better views on that than I.
So it is a single-arm trial of a technology that requires that a patient have a reasonable functional status to wear this bulky machine, and a single-arm trial that has a very selected patient population. And while the data looks, to the untrained eye rather reasonable, it isn't randomized. And we've been fooled many times before by trials in which a selected data set, patients look very impressive, and then you randomize it to a group of patients who are very similar, and suddenly it's not as impressive anymore. And the data is, comparable to the chemotherapy arm of the Checkmate 743 trial. So unless, I tell my patients, unless and until there is a randomized trial that compares this to standard of care chemo or chemo plus IO, chemo plus bevacizumab or immunotherapy, that I don't feel it is appropriate to offer. And I've actually turned patients away who have wanted me to give it. I've said, I do not feel comfortable using it. What do you do, Marjorie?
Yeah, I haven't used it. I have the same issues with the single arm data, and it's hard for me to invoke entirely new modality without randomized data. And it's hard to extrapolate from, the experience in GBM, which is a completely different process and tumor and biology, and to use that to substantiate it. So it's hard. And I think that a randomized trial in that space would really help answer some questions. I certainly found the response rate in the biphasic and sarcomatoid patient population intriguing, because that's a population that we all know doesn't respond as well to just chemo, but I'm not convinced.
Exactly.
I think it's intriguing. Yeah. Right. And I'd certainly put patients on such a trial were there one and we had access to it, but I have not prescribed it or recommended it.
Trial would be perfectly reasonable, but outside of a trial, there are too many other options that have proven data.
Yeah. So I know you guys touched briefly on the chemo IO trials. Hedy, you spoke about the one reading out in Canada with pembrolizumab, and we touched a little bit on the DREAMer trial with durvalumab. Are there other sort of things going on in this space that we should keep our eye on in addition to those two?
You've got stuff in the UK.
Yeah, I mean, in Europe, we are recruiting extremely well to the BEAT MESO trial. And in this trial, patients are randomized to the control arm of carboplatin and pemetrexed, this time with bevacizumab. Sort of extrapolating from the MAPS-1 data as the control arm that we'd like to have, versus the experimental arm of exactly the same thing, carboplatin, pemetrexed, and bevacizumab, with the addition of atezolizumab. And this is a really nice trial because it not only looks at the addition of chemotherapy together, immunotherapy with atezolizumab together with chemotherapy to see whether there's a benefit, and patients then go on to receive maintenance. But it also potentially synergizes with bevacizumab. And we know from preclinical data and in other studies that the combination of Bev and Atezo is potentially synergistic. Of course, we don't know that in Meso yet. But that's the rationale for the trial. The trial is recruited extremely well, despite our problems in Europe with COVID. Is nearing completion of recruitment, and so we're very much looking forward to data in due course on that. So things are very exciting.
I think we Americans are very jealous of your ability to accrue so well to trials. And to some degree, it's because in our country, we can obtain so many of these products even off-label before they're approved, and then they are also approved earlier. And that's great for patients, but that means that patients have so many other options that they may not necessarily join trials. But I think that trial is going to provide a foundation for understanding the role of VEGF inhibitors of the bevacizumab in this disease, and I think it's very exciting. So when do you expect it to read out?
Well, I don't think we're going to get an early result soon, so we're still recruiting. We're clearly in 2021, so we're going to be looking at 2022, I think, really.
So you expect completion by the end of this year, potentially?
Yeah, definitely. So, let's see where we go. We're not going to, I don't think, get a readout in 21. We're looking at 22 and beyond for a read on that. But, one of the things we've been doing in the trial is collecting tissue. You had to have tissue surplus to go into the trial. So we really do hope that we'll be able to get some really good, meaningful biological data as well to help us, really work out which is that group that need this 4-drug combination and which group don't. And then we'll have the really difficult job of trying to figure out where this regime, assuming it's positive, fits into this difficult, menu that we now have of chemo bev, IO, chemo plus single IO, chemo plus bev plus IO. It could be really very exciting times in Meso looking ahead.
There was another UK trial that was halted in the US, and that's the ADIPEG 20 study. And that was specifically for sarcomatoid and sarcomatoid predominant tumors that had, at least in early phases, some promising data. It was closed in the US because we now had doublet IO, and really many people felt it wasn't ethical to randomize to standard chemo in that setting. Do you think that study is going to be able to complete accrual?
I think it's still reasonable in the UK because we have pre-label access to Nivo-IPI, but it's not available everywhere, and we don't know what our post-label reimbursement will look like, whether it will be for all histologies or not. So at the moment, it's still very reasonable to recruit in this environment here in the UK based on the landscape of treatment options. And I do hope that Peter and colleagues can complete recruitment, although it becomes much more challenging when you have Nivo-IPI available and other competing IO trials in that landscape as well.
I'm concerned also that the DREAMER trial, which is a great trial of Durva, plus or minus Durva with chemo, may have challenges accruing in the US. And I suspect that it will principally be in the epithelial patients who are the ones we really need that question answered in, who are offered that study. But I think we'll simply have to see as that study rolls out whether that can accrue. Ex-US, I don't think it'll have an issue accruing.
Yeah, I mean, I think, as you both said, it's an exciting time where we never thought we would have so many options that we'd have difficulty picking between them. And I think this represents a lot of exciting advancements, and yet sort of fuels the next cycle of questions to ask and refinements to make. And I think I agree with the ADI-PEG story. It'll be interesting. And then I also think, well, what if the trial's positive?
Yes,
then what do I do?
But it's great to have so many questions and options.
Absolutely. But every answer is another question too. And so I think that having these conversations and coming together as a community, in these ways is so important to prioritize certain questions and to try to give patients, some perspective of all of the things that we're always considering when we give advice.
And then we have, of course, the molecularly targeted therapies, which have been so successful in lung cancer and in other cancers. And now that we've seen what we call precision medicine, the molecular on-off switches being able to be targeted in other diseases, companies are now beginning to broaden their approach in mesothelioma. And now we have a number of trials that are targeting the most common mutations, including BAP1 and NF2, and then several other smaller trials targeting several of the others. And so where those type of drugs fit in, I think we're still in the early stages. But as we then develop more data with these, we're then going to have to figure out where they go.
I think that's right. And actually, one of the really interesting things is, what is the role of checkpoint inhibitors in these well-established molecular subsets?
Do they have a role, or do these other drugs better? We don't know.
Exactly.
Yes.
So, I can see really we've got multiple strands of research that we're going to be doing. We're going to be doing our genotype-directed research with our TKIs for the right molecular group. We're going to be looking at IO in some subsets, and we're going to be looking at IO combos as well. And there's a good rationale for combining some molecular agents with immunotherapy as well. So I think this really is a very exciting area, and the key to all of this is delivering on research. We just need to make sure that the academic meso community continues to collaborate on ensuring that we've got the right trials set up to answer these questions coming up. I guess the other thing that we need to think about is, certainly in the UK, we're going to have some data coming out at some point not too long away on the role of surgery. We've been recruiting with the Mars 2 trial for some time now, and we've now completed our recruitment, and we're waiting for events to come through. Now, whether this will be 21 or 22 is difficult to know, but certainly that's a very large trial which has randomized patients to chemo alone or chemo plus maximal cytoreduction with extended pleurectomy decortication. And that will also read out potentially at the same time as our chemo immunotherapy trials are reading out. And that will, I think, really potentially confuse matters, or potentially streamline matters, or at least certainly throw in more evidence points to help us work out what the right treatments are for our patients.
And then, of course, do we need an immunotherapy versus surgery, or an immunotherapy plus surgery versus immunotherapy? Each question creates more questions, and each answer creates more questions. So it's a very exciting time.
Yeah, absolutely. I mean, I think that thinking about how we can, in some cases, we tend to focus on intensifying, at least in the US, I think, adding things and doing more and more. And I think we're reaching a point where we're starting to understand and be able to identify the people where we can actually de-escalate therapy safely and effectively with comparable outcomes, which is tremendous in the context of, a patient's everyday life and quality of life and, burden.
It requires a real change in how we think. We're not lymphoma doctors. We're not used to pulling back like that. And yet I agree completely. We need to begin thinking about who needs that aggressive treatment, who, for example, some of the germline patients who may have indolent disease for many years, maybe they need less aggressive, or maybe they need more aggressive. And so really trying to define who needs what treatment is a very exciting era. And then, of course, there's a limited number of patients who are actually able to go on trials, and a limited number of patients. So how do we choose which are the best trials that should be moving forward, and make sure that all of the trials are able to accrue? Which hasn't been an issue in this disease up to now, but maybe in the future.
Yeah. I think that, those were all the key points that I had really wanted to touch upon for today. I don't know if there was anything else salient you wanted to talk about, but I think you guys did a great job covering all of the questions that we field so much from the community, and I think they'll really enjoy listening to what you guys have to say. Two great experts sharing their inner workings of their minds with us, which is always a lot of fun to poke around in there.
I agree. This has been fun and really a nice interaction between the three of us.
I have to say I really enjoyed it, and frankly, I'd be very happy to do it again with all of you. It's great to chat to people. It's great to understand that we all have the same issues, the same questions, and great to get everybody's insight to these things.
I agree.
Absolutely. Thank you both so much.